here we go. So actually what they have told us today is going back to against all odds. How do you improve odds? We have to move from a very individual-based thinking to a population-based with community-based approaches, and have concerted and sustained policy, and help that little guy with the big ball up the hill with more people there, which would give us the population-based approach. So I'm sure you've all heard of Einstein, who made us think about all these wonderful things in life. Significant problems we face cannot be solved by the same level of thinking that created them. So constantly, we have to come up with different paradigms to address the challenges that face us. If we try to do the same old, approach it with the same methodology, same instrumentation, you're going to be where you were. You'd be like that, hamster in a wheel. So the shift also, it has to be from disparities, which is a rather deficit model. So disparities is, I'm doing worse than somebody, give me money. I'm doing worse than somebody else, so, I need research done on me. I'm doing worse than somebody, so make somebody worse off, right? So you can take any interpretation you want of that disparities, but we have to move towards an equity model, which really thinks about saying, what is the best health that is achievable for all communities and all people? And that will actually move us much closer to a social justice agenda. So, if we are repackaging, we would be having the same old policies, never address issues of social determinants of health. We would have the same research methods. Everything has to be done objectively. I came from a society where rapid response research was the ultimate. Meaning, when you were doing research and you saw the effects that it could have in the community that you were working with, you implemented it. You didn't wait till you objectively published it and came back 10 years later, had 10 generations suffer for it, and then decide that, hey, this is a great time. Or wait for so much evidence that you fill up all the libraries and computers and then come back to do something after a generation has gone. So if you're going to always do the same methods and methodologies, we're going to be challenged by it. And we talked about the paradigms. And what is your approach? Until and unless we take a transdisciplinary, community-based participatory research where everybody is equal partners at the table, you're not going to proceed further. So we need to address these inequities, but we're not likely to get the answers from the ways that we've been doing it so far. So, in this world of personalized medicine, which talks about personalizing things, being predictive, being preventive, and being participatory, you also think of the 4 W's. Who benefits from the work that you do? Because, personalized medicine is great, but I will guarantee you this, just like targeted therapies, it will worsen conditions for the underserved because it's not going to reach the underserved. It's going to reach the well-to-do first. And the gap is going to get bigger. Who suffers in the process that you have personalized it so well? Who pays for it? It's all your tax money, but only a few benefit from it. So who profits from it? So you create medications, you create drug therapies, which are very expensive, only a few people get it. So it's actually, it's a terrible story to tell, but I'm going to tell you the story anyway. So when I was actually meeting with tribes for a very long time, 4 years, went around the country with 2 of my colleagues, meeting different tribes to kind of launch on this intervention program. And this woman in a community heard me out very nicely and, got the full support of the tribe to move ahead, which is a pretty large tribe. She comes up to me at the end of my 45-minute spiel and she says, I was diagnosed with breast cancer. And I'm like, I'm really sorry. I hope you are undergoing some good treatment. She said, yes, I underwent some treatment. And she said, well, they gave me 2 rounds of chemo. And then IHS ran out of money, so they asked me to come back 6 months later. Now, she says, your work that you're doing is going to tell me whether I have breast cancer or not, because you're going to promote screening. But then what after that? So we have to, when we do research, be aware of who's suffering from it. Is there really something that we can get out of it at the end of it? So, participatory arose by any other name. Social science teaches us that. It teaches us critical thinking more than anything else. Ask the question, otherwise you'll never get the right answer. You'll always get the same old, same old. Is it at an individual level? Is it community research? Is it community-placed research? Is it personalized medicine? Is it clinical trials? Is it citizen science? Or is it community involvement at every step? That is community-based participatory research. Are we targeting prevention and health promotion agendas? Will it result in something which is sustainable policy change that affects health for all? Because there is no policy in this world that treats everybody equally. Policy has, by inherent in it, has a distributive effect. What is a distributive effect? Meaning some people will benefit, some people will not benefit from it. And we have to be cognizant of that. Because that is our role as social science, to put people's feet to the fire and ask those questions, who's benefiting from it? So actually, when you do an intervention, for example, and you do it in a white community, low-income community, and you do it in an African-American community, research has consistently proven that if you do a comparison of these two communities, the white community does tend to do better than the black community does. So what you really have to do is, if you were really a true interventionist, you'll have to do more than in this community to bring them up to speed. So it is not that you just do the intervention and measure it and then you say this intervention had XYZ effect. Methodologically, that's great, but you have to bring the speed up, and only then can you really do a true trial. But we don't do that, do we? So what are the lessons learned from social science? We say account for the context. It's very important. Who is included when we say who's included in the research? Be aware that people are excluded from the research. In studies, in surveys, and in trials. Ensure that the work that you do is relevant. And that's what Protect is trying to do. By bringing all these community organizations together, it's ensuring that this research that they're doing and the work that they're doing is relevant to the communities that they're working with. What is the context of the measures that you're doing? I don't know. But I know we talk about health literacy when it comes to the underserved populations. I'm one who lacks health literacy. I'm in a doctor's office, give me a diagnosis for a disease, and I am all thumbs. It happened twice over. And I didn't know what he was saying, and I was like, what? What are you telling me? I have what? And suddenly I've become like this third grader who doesn't understand one word in medicine or being said to me. So health literacy is not something that is only for the poor or the people who don't have a high school education. All of us need health literacy. What are our statistical methods and analyses? They can be very nuanced. We leave out noise factors, right? What is that? You want a clean data set, we say. We want something to really compare very well. Just take that out. And we come up with good reasoning for it. We say there are assumptions we make. Build transdisciplinary partnerships, as that's what social science teaches us. Scientists can be also skeptical. Don't believe that all scientists know exactly where they're headed with what they want to do. It requires a commitment which all of them may not be willing to give. Communities also can be reticent, but communities can also be very ready to do the work that they want to do. But then the scientists need to get over their skepticism and come to the table too. Build trust. One of my colleagues always says this. He says, what we lack in America is the empathy gap. That is the biggest factor in America. What is the empathy gap? Wealth has made the empathy gap less. It's happening to somebody else, somewhere else. It doesn't affect me. I am here. And we come up with things like, oh, they are in a place where there is gases. They could move out. There is unemployment. There are other places that have jobs. They can go there. The water's not good. Drink bottled water. So, we have this empathy gap. We just don't care. And that is a very big problem. It is inertia that is built into much of the work that we do to go that extra mile. So, and then there is, of course, we talk about ethics of research that Millie and Akram also brought up. What are the ethics in what we do? The community and scientific advisors and the feedback loops that Millie talked about, how are they going to give this material back to the community? How are they going to communicate with the community? You know, when people say, you know, these are words that we use, language is so powerful. You know, we use language in such a bizarre manner. When it comes to doing work in an underserved community, you say you're going to tailor or target the information, the intervention. But hell's bells, you targeted the intervention to the group that you started with. You mean to say you built it for somebody else and brought it here? No, you targeted it to begin with. But if I take it from there and put it in an underserved community, suddenly it is tailoring, suddenly it is cultural relevance, and suddenly I am doing something very different with the intervention. It was different to begin with. So we have to be very careful about the language that we use. So in evaluation, are we doing evidence-based practice or practice-based evidence? I'm done. And the community, does it have access to care and support? Does it have the support needed to carry out this work? It's not only access to care, but it can be quality of care too. You can have a mammography facility, but if it is not accredited, you better believe you might get a result which is not right. And it is happening a lot in Chicago. Institutions, what is the quality? How are the services provided? So you have to be able to think at a population level, but act at a local level. So we are developing two agendas. There's population health interventions, so going beyond the behavioral, also looking at the social determinants of health. We're also looking to do work on small populations. We just published a paper in AJPH looking at how do you work with small populations, people who are left out of studies consistently. I mean, there are groups and groups. Do we not have the methodologies? Do we not have the analysis technique? Do we need to look at other sciences for it? And we reorganized and we are more interested in health services and healthcare delivery research. So I'll end with this. The I in illness is isolation, and the crucial letters in wellness are we. Healthy communities have hope, and those who have hope have absolutely everything. Thank you very much.
Okay, thank you so much to all the presenters. I'll just go ahead and invite them to come up front here so that we're able to take questions. And we do have a couple of microphones coming around. So I'll give them a second to get up here. So we'll have about 10 minutes for questions. Thank you. Right. Up here in front.
Hi, can you hear me?
Oh, yes.
Hi, my name is Caitlin. I'm an MPH student at Northeastern. I found your comment towards the very end about the empathy gap to be very interesting because that's something I've actually experienced frustration with in regards to some of my classmates. I remember in a class we had a conversation about, I think it was actually about fracking, and somebody said, well, why don't people just move? And I just had this moment where I looked around like, really? Because they can't afford to, because their family has lived here for 6 generations, and the person honestly couldn't comprehend why they wouldn't just move. So what would you suggest to say to someone who is struggling that much to see through another person's perspective?
I think the answer lies with people like Millie, who are really doing the work at the community level and trying to educate people. I don't think I'm the answer to it. Millie and people like them are the answers to the question.
I want to say that I get that a lot from students in public health, and I also teach in the School of Medicine. And what I try to do is they have to leave the classroom in my classes. I mean, sometimes they're there for 2 years and they have not ever had an experience out of the building. So they have to do, I use, photo voice as a technique, and I just tell them, you go out there. There's one experience that is almost, it's a requisite in the courses that I taught in the master's program. And they have to go to this community that is in the metropolitan area. It's like 5 minutes from the university, where people have lived in a an area that's very, very contaminated by the water, the water that's close, because this was a very poor community that moved there, and the way they made their houses was throwing garbage into, this is 100 years ago, garbage into the swamp and creating that. And so this is one of the most contaminated areas, the place where there's most poverty, but it's also one of the most strongly struggling communities. They've been able to organize, they have this project where they had 700 meetings in that community, and they were able to get a project going where they have a community title over their properties. They're all owners of the whole community. And they're fighting with the EPA, they're fighting with everyone to get that area clean. So I send the students there, and when they come back, they're like, I didn't know that was there. You know, I think that we really have to give people the opportunity to go out there. When we are forming students, the classroom is just not enough.
Yeah. Take the next question.
Thank you. So I have a question about the product use versus the general environment, and if you have some data on that, if you have some results, or if you're going to be able to parse out sort of like the impacts that are based on product use in the home versus the general environment. And if you could talk about what those products, what kind of data you're collecting on the product use.
Was that? I told Jose to come sit with us, so I will switch it.
Yeah, the product use, well, the reason that we have a product use is that our primary hypothesis relates to phthalates and EPA and other sort of products that are really mostly at home. We also want to look at pesticides and so on. So the whole issue of the product use is all based on what are consumer products that are often found in the home. We actually want to consider doing things like taking dust samples in the home. And when we look at the possibility of doing this, it was actually not very feasible. It would have taken a lot more than we were able to do. So it is really a lot of what's what in terms of commercial products in the home.
We also look at personal care products, especially makeup, and because for Latinas, makeup is very important. So there's a lot of use of these products.
Hi, Diana Hernandez. I have a question related to the kind of threes. So the low income, high poverty, high education, and whether or not with the population and the participants in the study, the higher education has been leveraged in any way to kind of help inform different remediation strategies or just kind of awareness. Usually in a kind of a health disparities context, the low education is a huge barrier, but in this case it seems like an opportunity.
It's actually one of the things that we are trying to look at. We haven't get to that point yet, but we did some analysis on things as, for example, water use. Who will be using more, the have or the ones that don't have, and you realize some of it is just because people can afford more does not necessarily that they have more awareness about the impacts on the environment. You can have sometimes more education with the lower income about the environment. So these things we're still looking at, and hopefully we'll have some better information on that.
Barbara Loftus, Clark University. Thank you for a really terrific panel. My question is, in interviewing pregnant women about their exposures, about product use and other exposures, are you looking at past exposures or current exposures? And if you're looking at current exposures, what information do you give back to the women, and how do you justify the decision you make about that?
I guess when it comes, we'll be doing past and current. The past exposure, we're doing it by collecting the data about the water quality, the historical data, and get through some modeling, some analysis over time for the past couple of decades, not only recent exposure. And then, of course, the questionnaires we collect, we do more about that. How do we convey that information? That's what we're working right now with Phil and the Silent Spring Institute. What exactly? Again, when we started the project, we didn't have a community engagement core, and we didn't have that component until just last year. So we are right now building those. We're starting with only a few chemicals that we said we will identify and focus on. And then as we move forward, we'll develop some strategy. And those are things, again, that we discussed with Phil and Julie about those.
I mean, what I meant was if you discover that when pregnant women are being exposed.
Yeah, risk communication. Jose, I think that's something it's in your field.
Can you repeat the second part of the question?
If you discover that pregnant women are through product use or other exposures are currently during their pregnancy being exposed to substances that may have an effect on their fetus, how do you justify collecting the information and then not doing rapid response, not immediately saying something to them?
Okay, I think that many of the things we're asking about, we don't know whether they actually would have an effect. But if the experience we have had, say, someone is taking a drug that may be a teratogen, or that basically we work with the obstetricians and we do work with that. Let me just give you another example. One of the things that we know that actually is very important in terms of reducing risk is like influenza vaccine. That is, and we actually developed a supplement and actually been working on educating women about the importance of getting the influenza vaccine. But the answer is absolutely. If we do find something that actually is a known adverse factor, we work and we do it with both the patient but also the physician. We have a very great relationship with all our obstetricians and pediatricians and the clinics, and so this is part of the ongoing dialogue.
With the help of our trainees, we do talks at the clinics when they're in the waiting room on nutrition, on safe product use. When we go into a home and we see those huge bottles of we tell them, as best we can that maybe there's some other way that you can. But we're developing materials so that we can provide something that's more constant that we can follow up on. We've just begun, but there's no way we're going to walk in there and not say anything. We've even developed these bottles so that we can tell them, this is, you want to drink from here. You want to put your water in here. You want to, so that we can start, doing some education that is hands-on. It's something that they can use.
We have time for one more question. Great.
Thanks for that really nice detailed presentation about the PROTECT program. I've been following it for some time, as you know. But I have a question about strategy. So we know that there are a lot of social, cultural factors related to preterm birth, and there's a lot of literature on comparing different ethnic and racial groups. And in Puerto Rico, you have more of a homogeneous population, but there's still many of these social factors that are going to be at play. And yes, we're focusing on new risk factors, environmental agents, because they're less studied and we don't know more. So what's the strategy for the program to look at the combination of the risk factors? What's the causal web that you're hypothesizing? Because what I would hope we wouldn't see would be just controlling all of these other factors to focus on a particular individual chemical at the end of all the data analysis. So I'm assuming you have a lot of questionnaire information about these factors and how access to care, et cetera, is places. So I don't know, maybe Jose is the one who can speak to that. But that goes back to this, chemical and non-chemical stressors all working together in the disease etiology.
Yeah, thank you for the question. First, one of the advantages we have in this is that we really have actually looked at a lot of the access issues before we started PROTECT. And part of the reason was that it isn't cesarean section, it isn't a smoking, it isn't going early to prenatal care. In spite of all those things improving, we have rates that are actually going up. But having said that, we also have actually part of the analysis is actually to look at this in a sort of multivariate fashion. And for example, we have a lot of questions that relate to stress, and not only stress, look at two different ways in terms of specific events, but stressful events and also environmental. So that's one example of things that we are looking at as being also in the same direction as sort of inflammatory processes and so on.
All right, thank you so much. Please join me again in thanking Shobha, Akram, and Carmen.